All right. Everybody says you should do it, but nobody tells you exactly how it's done. We're talking about telemedicine, and I'm extremely fortunate to have Courtney Lord, who is the billing manager for Austin Urology Institute, in the program today. Not only has she thought about it, their office has already started using telemedicine for their urology patients. So thank you so much for letting me interview you, Courtney, and welcome to the program.
Thank you.
Okay, can you tell us how you all started this telemedicine in urology?
Yeah, so Dr. Shaw just was trying to figure out a way just to maximize patients' time as well as his time. And telemedicine was a hot topic at the time. So we started back in 2016, and we are going strong now still.
So definitely veterans. So you guys saw that there may be a demand, there's a need, and I know that Austin Urology Institute tries to be a leader in the urologic care delivery. So 4 years ago, you guys started.
Right. Yes, sir.
Okay, can you tell us how that rollout happened?
Yeah, we started initially scheduling, say, 3 or 4 patients one afternoon just to see how it would go. Patient feedback was amazing. Dr. Shaw's time was utilized great. So we just kind of started incorporating more and more patients each afternoon. And now we are seeing anywhere from 20 to 50 patients a week on telemedicine.
Okay, let's roll back a little bit. So you saw the need, and then what happened after somebody, Dr. Shaw said, "Okay, we're gonna do this." Tell us what happened next.
Basically, we just kind of figured out which patients would be good candidates for telemedicine, and then went from there. We don't do really any new patients. It's mostly follow-up patients, and it's just lab results, test results, things like that we see patients for.
Okay. So that's patient selection and identification. Let's go into that in just a little bit. What so you obviously don't say, okay, well, let's do telemedicine. How? So first of all, the type of vendor. How did you pick the vendor, and then how did you roll the program out to the patients, and then of course the big hurdles are regulatory and reimbursement. So let's start with selection of the vendor.
Selection of vendor, we have Athena as our EHR system, so they partner with Chiron.
Got it.
Um,
Chiron
it just
Health.
much easier. Yeah, Chiron Health. So we just went with that, of course, since it was already incorporated into our EHR system.
Okay, so that made it easy.
Yeah, definitely.
And how? Tell us about the integration. How is the integration between Athena and Chiron Health?
So when we schedule a patient's appointment, there's a specific appointment type called Chiron. So we just select that. As soon as appointment is made with Chiron, it's integrated in our system where Chiron automatically emails the patient a link saying, hey, your next telemedicine appointment is this day, this time. Follow this link to create your profile. So at that time, patients create their profile, and then they're ready to go for the telemedicine appointment. So it's really nothing. We didn't have a lot to do on our end with it, as far as integrating and all of that.
Wow, that's a really ideal case. I
Yeah.
think most practices are not going to be able to just say, okay, EHR vendor has a tight integration with Chiron or American Well or one of the other, yeah, electronic telemedicine companies to be able to do that. All right, so you had that going for you. So the technology hurdle is gone, and then comes to patient selection.
Mhm.
How, I mean, okay, so great. You are seeing established patients for telemedicine. Talk to us about how that journey begins. How did you identify the patients, and then who identifies the patient, and then what is the checkout process to get those patients on an appointment? Tell us how that works.
So Dr. Shaw will see the patients initially, go over plan of care with them. At that time, he will send the patient to the front. On our appointment return information, he'll put Chiron Health. He tells the girls at the front which patients are good candidates for Chiron or telemedicine, and that's how the girls at the front know which patients to schedule.
So basically, he telegraphs to the checkout person through the EHR or somehow
Right,
that this next follow up is going to be a telehealth visit. And he
right,
also, does he specify when
right. He'll
okay,
say 3 months, 6 months, one week, just kind of depending on each patient.
perfect.
Mhm.
And so the checkout person makes the appointment for a telemedicine visit. And
Right.
tell us what happens before that actual appointment. I assume that there'll be, let's see, reminders to the patient.
Yeah, so in our Athena Health, we automatically send a reminder 2 days prior to their appointment. The day before their appointment, our front desk will call them, remind them of their telemed appointment, collect their copay at that time, and then just tell them, remind them to log on, create their profile on Chiron if they haven't already done so. That way, whenever the physician logs on and they log on for the first time, it's a seamless process.
That seems easy to do, but have you had any patients who couldn't figure out how to do that, and how is that handled?
The only time we come across a few where their audio and video won't connect, in that case, they just change the visit and do a phone call visit, and we bill for a phone call. It rarely happens, but it will. Of course. And our patient population generally for the telemeds are younger patients, more tech savvy. So we really don't have big issues. Chiron has an amazing support. So if we have any problems, the patients can get on call Chiron. They walk them through, and usually they can help them with any issues they have.
But that doesn't really help if the patient's got an appointment time and your Dr. Shaw's already ready to see the patient and patient's having technical difficulties, and then you end up having a phone call. Is that right?
Yes.
And how is that phone call billed?
It's billed as a telephone consult.
Okay. Is it you guys bill a specific CPT code?
Yes, but I don't know right now
Oh,
which
no,
one
no,
it is.
no, no. Not to worry. I know there's a 99 something, maybe a 9923 something. I can't remember either. That's okay. We can always look those up. Technical difficulties. That's one of the things that we have to be mindful of. So you're not doing this on Medicare patients. Is that correct?
We are not doing it on Medicare. We can if the patient wants to. At that point, we would get them to sign an ABN since Medicare doesn't cover it, and then we would collect in full for a self-pay rate.
Got it. And we don't want to have any allegations of collusion, so we're not going to talk about pricing
Right.
and how much you charge.
Right.
So great. Now say everything goes perfectly.
Mhm.
Does Dr. Shaw collect, like in 2020, history, review systems, and all that stuff at that visit, or how does that work once the telemedicine visit starts?
Yeah, he collects all of that at the visit. Just kind of goes over everything from their last visit when they were in the office, to see if anything's changed and all of that kind of information.
Okay, because right now when the patient presents in real life, that is
Mhm.
done for me, and I don't have to do that, and that's one of the efficiencies in when I see the patients in real life. But in
Mhm.
telemedicine, now the physician, the most expensive employee, is doing that type of task that could be delegated to somebody else. That's important. That's an important thing to know when it
Right.
comes to time value, the opportunity costs and the time that the physician is actually spending and doing documentation. Because I think one of the biggest things with burnout among physicians is the amount of documentation and also data entry, if you will, that we
Right.
all have to do. So I'm
Right.
trying to figure out how do you minimize that, and how can you optimize that type of service in a telemedicine type of format, so that the physician does not become a glorified data entry clerk.
Yeah, we have our MAs occasionally call and do health history over the phone the day before. It just kind of depends on availability and if what the MA schedules are like. They can certainly do that initially prior to the appointment if they want to log on first, get all that information from the patient, and then the doctor pops in.
Okay, and just for the viewing audience, we are streaming this on Facebook Live on the Thriving Urology Practice Facebook group. So those of you who are watching, Emmett, Ben, Karen, if you guys have any questions, please feel free to ask, and I'll try to relay the questions to Courtney. Okay, so now the Dr. Shaw sees the patient, and then so what happens is, so say it's review of labs.
Huh. He'll go over lab work with the patient, discuss next follow up, any kind of medication, do medication management. After the patient's seen, he will then send, he does all of his own coding, so he'll code the visit. He will send a message to the front desk staff. This patient needs another follow up in 4 months or whatever the case may be. The front desk staff then calls the patient, schedules that, and patient's done.
Okay, what if an imaging study or a lab is ordered?
Then
How
that
does?
the nurses, he'll send it directly to the nurses, and they'll order all of that. And then they will come to their next follow-up visit will not be a telemedicine. It'll be an in-office visit. We
Oh,
don't do telemedicines back to back.
oh, that's interesting. That's an interesting thing to note. So there, you do not do telemedicine, telemedicine, telemedicine. You do telemedicine, and then in real life, and then maybe go back and forth like that. That's an interesting. That's the interesting thing to note. Is that something that was suggested by Chiron, or just something that you guys came up with?
Something we came up with just for patient care.
I think
That
that's a
way,
good idea.
patients stepping in the office and we're physically seeing them. So
No, I think that's a safe. I think clinically that's a good idea to be able to see the patient and then physically examine the patient in real life every other visit. So I think that's a neat something that I hadn't thought of. Like
yeah.
how do you? I'm always thinking about the entire workflow from beginning to end, and how do you close the workflow loop?
Right.
Okay, let's go back. The type of patients that you guys see.
Medication management, for instance, low T patients, we see a lot of that.
Testosterone, okay.
Anything for like kidney stone, if we send the patient, they come in the office, get a KUB, we'll call them with KUB results.
Okay, review of KUB results.
Our nurses do not give any test results over the phone. Everything mostly is via telemedicine or in office.
Okay. That's our policy too. I mean, if the patient wants a copy of his or her results, we're happy to fax that, email that, or however they choose to have it delivered. But as far as interpretation of the results, that is something that should be done either telephonically or through telemedicine or in real life. Yeah, so we generally do not do that over the phone, actually.
Right.
Yeah, yeah, because I like to look at the images myself. When it comes to, okay, so lab results, imaging review, any other visits that you guys?
And we do 24-hour urines. We'll give patients results for those over the phone.
Okay, lab results, and then coming up with interpretation, and then game plan.
Right.
Okay.
And then United Healthcare recently, they stopped paying for us for consults for vasectomies the same day that we do BASs. So we decided to start doing our initial consult for vasectomies via telemedicine. And then when the patient comes in, Dr. Shaw will, of course, examine them again and then perform the procedure. We don't like the patients to have to come in for 2 visits just for patient convenience. So we started doing that, and it's working out pretty well.
Oh, that's neat. And I think so this is something that has not been addressed by anyone that I know of. Starting 2021, I think telemedicine is going to work it's going to work real well for patients and new patients, seeing new patients that do not require physical examinations per se. But it's a new problem requiring additional workup. So I think it's going to play favorably for physicians and patients when it comes to telemedicine in 2021, once the CPT, the E&M changes occur for all of us. So I think that's going to be really key. Okay, so lab results, imaging, 24-hour urine, medication refills. What else? What are the other visits?
That's pretty much all we do.
Okay. Let's go back to regulatory. Did you guys have to jump through any hoops other than the ABNs that Medicare patients have to sign? Any other legal
Not
hurdles?
the Chiron's already integrated to our EHR. We didn't have to go through pretty much anything. It just kind of fell into everything with our EHR system.
And on your new patient intake forms, did the patients have to fill out anything that is different when it comes to billing for telehealth services, or is just kind of pretty much this is the way it is?
Pretty much our standard new patient forms. It just falls into our billing policies.
Okay, let's go into once Dr. Shaw sees the patient and then advises the patient that he wants telehealth follow-up. What is that talk track like?
Basically, Dr. Shaw's like, hey, we have this new thing we're doing. It's telemedicine. It'll save you time driving into the office. It'll save you time waiting. He's like, we can do it on your lunch break. We can do it after work. He just he actually talks to the patients about it. We have stuff on our website talking about how we offer that. We have brochures that we give patients saying, hey, we do telemedicine now. So it's just pretty much advertised all the way around.
Who created the brochures and that information type stuff?
Our office manager actually did. She kind of put everything together just with a bunch of information for patients and just kind of the pros and cons, well, the pros of doing telemedicine.
Okay, so I'll see if I can get that in email format, or maybe you can take a picture of it so that I
Yes.
can see what that is like. But I think that's a great idea. And one of the things that I try to do on the Thriving Urology Practice Facebook group is that I hate for everyone to reinvent the wheel. So
Mhm.
this method of information dissemination is going to help everyone. So once again, I really appreciate you sharing your insight on how to do this.
Sure.
When it comes to okay, so regulatory wise, I think you're covered. Does Dr. Shaw do anything? So telemedicine, first of all, there are interstate compacts that are being developed. I think about a dozen states have that, where telemedicine can be provided across the state line. But really, there you in Arizona, I cannot practice medicine in California, even via telemedicine. So
Right.
how do you guys make sure that the patient is actually in Texas, where you're located?
It's more on the honor system on the patient's part. Whenever we initially get on the call, we just ask them, hey, verify your name, your date of birth, and your address. And they
Okay.
give us their address. So we're getting verbally from them their address. So that's how we do it and just hope that they're telling us the truth and they're at home and they're not in Hawaii on vacation or something.
Yeah, that's true. Okay, so yeah, the hurdles are regulatory and reimbursement. So regulatory, I think we kind of covered that pretty well, and you guys have a nice integration with Athena, so that's a nice thing. When it comes to reimbursement, so Dr. Shaw sees the patient, comes up with the plan, and then sends a message to your checkout person to make the subsequent visit appointment and follow-up plan. So that requires staff time, not unlike when the patient presents in real life. So, okay, I'm just trying to compare the two and think about the workflow. And then he submits the claim to your billing person, and that closes the encounter. And then he waits for the next medicine appointment. Okay,
Yeah, we schedule them in 30-minute increments. His time usually is 20 to 25 minutes per patient. So that gives him 5, 10 minutes to kind of get ready for the next patient, review the chart, and then they just log on and he just stays logged in and the next patient pops up.
got it. Can you? I was going to ask about. Oh, templating.
Mhm.
You said appointments during lunch and then after work. Is that when these telehealth visits are templated?
Yeah, so we usually do from noon to 7 p.m. That gives the patients that are at work time during lunch or after work. Sometimes, of course, there's breaks in between where we don't have a patient for an hour. So we try not to let that happen. If it does, our front desk staff will try to move patients up, move patients down, just to maximize the physician's time. That way, they're all like in a little bundle when he's doing.
So it sounds like you have a set telemedicine afternoon going
Mhm.
from 1 to 7 p.m.
Yes, sir.
Okay.
We do every Wednesdays. If there's overflow on Wednesdays, then we'll do like Thursday evenings from 6 to 9. It just kind of depends on the patient demand.
And the originating site is, I guess, Dr. Shaw is in the office,
Yes.
and the patients could be anywhere
Right.
because we're not dealing with Medicare,
Right.
which has onerous requirements on originating site and also the site of service, the place of where the patient has to be. It has to be in some special place, and it has to be in a health professional shortage area and all that stuff. So we're not dealing with Medicare. Thank goodness. This is free enterprise, mostly market-driven type healthcare, which is awesome.
Yes.
All right, you being the surgical billing manager, can you speak to billing and coding regarding telemedicine visits? Any
Yeah.
caveats and
We just bill place of service number 2. I know the GT modifier they're stating is not required anymore. We still put the GT modifier on the claim, and we haven't had any issues. It's still getting paid. The one thing with Chiron that we like is they have a guarantee. So say they do all of our patient estimates up front, whether or not and check eligibility on whether or not the telemedicine is covered or not. If it is, and we come back and get a denied claim, they will help us fight the claim. If it still gets denied, Chiron has a guarantee where they will cover the claim 100%. So the
But
provider is not out of
but
pocket.
but that is claims against a insurance company, not
Right.
self-pay.
Right.
Okay, because I know they have, oh gosh, they have an insurance verification engine or something like that that allows them to check eligibility and benefits. And if you go on their website, you can download some white papers and their services and how they do that.
Right.
So GT Golf Tango would be the modifier for the E&M service, and then place of service is 02. So those are pretty much the caveats, right?
Right.
Because it's just a pretty much an E&M visit, and that's it. There are really no 52 modifiers and 22 modifiers, for CPTs and E&M visits. So that makes it pretty simple. No UAs that you have to worry about.
Right. And reimbursement's the same as the regular E&M visit in the office.
So not all. I know over 30 states now have payment parity when it comes between actual office in real life E&M visit and also telemedicine E&M visits. So that's something good to know. And it sounds like Texas has payment parity.
Yeah.
And I know Arizona has, I think, as of a couple of years ago, thanks to our local legislators and also Jason Jameson, who's a urologist here locally. He's very involved in the legislative side of things. So very, very good. All right. You guys don't deal with Medicaid, so we won't cover that. Medicare, we kind of addressed it multiple times. So this is mostly private payer. What if a person has no insurance?
Then we have a set self-pay rate for telemedicine, and we just collect that the day before, like we do with all of our telemed patients.
So when you say collect the day before, you're talking about someone from your office contacting the patient.
Right. Yeah, we have our checkout girl. She'll call and collect patient payments, copays, deductibles, whatever the patient's out of pocket is due for their telemedicine visit.
Interesting. I wonder if anyone does. Have you thought about just having credit card on file and then just collecting that with? It's kind of like the hotels. Hey, will we be putting this to your room, charging this to your room?
We do. We keep a credit card on file for all these patients. So say we collect a $20 copay and they come back, insurance processes the claim, it was $50. Well, their credit card's automatically charged the additional fee.
Well, that's great, and that's another feature of your EMR PM.
Yeah. Mm-hmm.
That is wonderful. Let me see. There are some questions from the viewers. Connie says, listening. And Garrett, Dr. Pullman says, have you had any issues with no-shows? Well, that's a great question.
Yes, we have. And
how do you manage that?
A no-show fee, just like we charge no-show fees for the office.
Okay, a no-show fee. Okay. And I assume that you set at the very beginning of the visit with patients' initial writing initials next to the policy or signing on that document.
Yep, correct.
And then you have language specific to telemedicine or just any office visit, any visit actually.
Any visit.
Okay, no, that's good to know. And how often does that happen?
Oh, it doesn't very often. Just since we do a 2-day reminder, since we do call the day before to collect. Most people, if you collect their money, they're going to show up for their appointment. So we really don't have it. We have had it happen maybe a handful of times, but we just send them, charge them no show fee.
Yeah, that gets kind of messy because I guess you never charge the copay and deductible. Well, if you call them the day before, and you charge the copay and deductible, now you have to refund the copay, process a refund for that copay and deductible that you collected, and then charge, or I guess you would just charge the balance of the copay and the late fee, I guess.
Yeah, that's what we do. We just charge them the difference between the no-show fee and what they charged or what they paid.
I love it. Love the tactical stuff. This is what everybody needs to know and wants to know. That's what I want to know too. Karen says, I missed the first few minutes. What insurance companies pay for telemedicine? I guess that's going to be geographically dependent, and depending on where you practice. Healthcare is so regional. And Texas may be different than in California versus Arizona. So do you guys have any payers, private payers? I know you're dealing with mostly private payers and self-pay. Do you have any private payers that don't cover telemedicine?
The only one that we really have issues with right now is Aetna. They are certain policies cover, certain plans don't. They cover mental health for telemedicine, but
Ah,
not regular physicians. But it's just dependent on each policy. And again, we just figured that out when we verify initially.
yeah, Karen also said that we are also on Athena. And for those of you who are joining us a little bit late, we are on Facebook Live. So if you guys have any questions, please leave them in the comments, and we will try to answer them as best we can. So what are some of the downsides that you notice from your perspective when it comes to telemedicine?
We really don't have any. I mean, the patients are taken care of. They have the same care telemedicine as they do in the office. And we really haven't had any issues at all.
And it sounds like you've kind of overcome the hurdles, the two biggest hurdles, like I said before, regulatory and reimbursement. Sounds like you've taken care of that issue. The only concerns that I have are the inefficiency when it comes to gathering historical data, that the physician now has to do it, which is, Dr. Shaw is the most expensive employee, and not knowing how much he charges, the opportunity cost is always a concern for me. When I think about telemedicine, I think there's definitely a demand, and I think whether the patient is far away or close to the office, I think that's moot. The time savings and the hassle factor, the driving, the risk that you take, having to drive to an office and possibly having to wait in a reception area. So I can definitely see the demand, but on the provider side, in order to see, you want to make sure your services are going to be optimally utilized. So I'm not sure if every 30 minutes per patient is an optimal use of a provider's time. So yeah. I totally get that it's beneficial for the patients, but I'm also thinking in order for this to have mass adoption, we have to overcome the regulatory reimbursement hurdles, and also the workflow, and the opportunity cost for the physician is a big one, because now he is not only is he inputting all that information into the EHR, now he has to actually gather that information, which is in my opinion not very efficient when it comes to 2020. I know it's changing in 2021, but 2020 we still need the history section,
right,
for an E&M visit.
Right.
But I guess for private, if it's self-pay, that's a totally different issue.
Right.
All right. Any other final comments? I know, aren't you presenting on telemedicine coming up?
Yes, at the SUNA conference in Dallas, March 27th. I'm talking to a bunch of the nurses there, so regarding telemedicine.
That's great. I'm sure you'll go into much more detail about the difference between telemedicine, telehealth,
right,
and the regulatory hurdles, the state dependence coverage, and all sorts of good stuff.
Yes.
Patient selection.
Right.
Awesome. Well, I am not seeing any other questions on the live stream. So anyone who has any questions later on, if you're watching this on a replay, please feel free to leave them in the comments. And I want to thank you one last time, Courtney, for doing this. I really, really appreciate it. I think you're helping a lot of people. And thanks to Dr. Shaw.
Yes, thank you so much for this opportunity.
All right, if you guys have any questions or concerns, leave them in the comments below. If you're watching this on YouTube or any other video playback media, if you like this, give me a thumbs up or hit the like button, hit the subscribe button, and notification bell and all that good stuff. You know what to do. Have a good night. Bye-bye.